Good morning, friends. It's so heartening to see so many of you here at such an early morning. All calculations in special situations, that's the topic of my day. Well, and what are these? These are post-refractive surgery eyes, which is now going to be so rampant because probably in 5 years' time, every third patient whom you operate might have a refractive surgery done of any kind. It could be a corneal based or even it could be a phakic lens. Silicone filled or posterior segment surgery eyes. You know, our retina colleagues, they are also now not left behind, and they also do a left, right, and center lot of surgeries. Very long eyes and post-staphyloma, short eyes and polypseudophakia, where we might need 2 implants. Right? This has been very now successfully and largely done, trying to correct very strong numbers by 2 implants and not by only a single implant. Of course, pediatric eyes is in itself a different topic, and eyes with corneal opacity or along with some keratoplasty or some procedure done. So these are the situations which I'm going to cover. The first one is silicone fill eyes. Well, silicone dampens the velocity of ultrasound. How many of you know and how many of you change your velocity whenever you have silicone eye fill eye? Do you change your velocity in the machine, in the ultrasound machine? Does everybody know that? Okay, thank you. 1000 MPa silicone oil slows sound waves to a little more than half the speed, that is 980 meter per second of normal vitreous, while the 5000 MPa silicone oil and higher, they slow sound waves sound waves to approximately 1040 meter per second. So they have usually erroneous axial lens such as 35 mm, which are displayed on a scan. Many times the patient might not have given a history, but the moment you find such a kind of reading on your axial lens, you try to ask and you might be surprised. The patient say, yeah, I had a silicone eye done and I forgot to tell you. But usually most of the time the patient also reports. Each component of the eye had to be individually measured, usually at 1532, and the true axial length calculated using the velocity conversion equation, TL blah blah blah, for the lens thickness and the vitreous cavity. What was once a time-consuming, difficult and sometimes inaccurate measurement by USG is now simple and highly reproducible with optical biometry. How many of you in this hall use optical biometry? Yeah, so still a lot of people go ahead with the conventional. And I am sure all of them use the immersion mode. Now the contact mode of scan is already gone. I believe that is the message which should be given to everybody. Adjustments to intraocular lens power. Holliday and others, they have recommended that biconvex intraocular lenses should not be placed in patients who have silicone oil in the vitreous cavity. Instead, this patient should have a PMMA convex plano lens with the plano side oriented so it is facing towards the vitreous cavity, and preferably over an intact posterior capsule. This approach prevents the silicone oil from altering the refractive power of the posterior surface of the intraocular lens. By contrast, a 20 diopter biconvex intraocular lens would lose 1/3 of its refractive power if it comes into contact with the silicone oil. For an eye of average dimensions and with vitreous cavity filled with silicone oil, the additional power needed for a convex plano PMMA intraocular lens is typically between +3 to +3.5 diopters. Okay, the second category is the long eyes and the posterior staphyloma. This is somewhere where even the optical biometers go wrong. Am I audible? Yeah. No, right? Not, yeah, I thought so. Incidence of posterior staphyloma increases after axial length of more than 26.5 mm. Can I have some water, please? An axial length of more than 33 millimeters have 70% chances of staphyloma. This is, thank you. The most posterior portion of the globe, anatomic axial length, may not correspond with the center of the macula, which is a refractive axial length. I think you all know this principle. And the simplest method by which to measure axial length in the setting of a posterior staphyloma is by optical biometry. Patient looks directly at the red fixation light and the axial length measurement will typically be to the center of the macula. Well, this is a visual axis. Non-available optical biometer and immersion vector AB scan can be used to measure the axial length of the center of the macula. But if somebody has a B scan, I'm sure he has an optical biometer also. But just in case if you don't have, you can do this. Corneal transplantation again is going to be a big challenge. There is presently no method that can be used to accurately carry out IOL power calculations prior to corneal transplantation combined with cataract removal and intraocular lens implantation. You might fellow eye or try to go by the history method. After 4 to 8 months, when the corneal curvature has stabilized and corneal astigmatism has been minimized, a careful aphakic refraction is performed and simulated keratometry by topography is used to estimate central corneal power. Now, a lot of other new terms have come: central corneal power and true effective central power, and all these are available with the high-end machines which are either topography based or the scan fluid camera based. And the power of a foldable secondary intraocular lens is calculated by means of the refractive versions formula. Not necessarily everybody might go with this method, but this is one of the options which is available to leave the patient aphakic and then go ahead and implant an IOL. And then it's of course placed into the ciliary sulcus, but confident people can go ahead with a primary implantation and just in case might do adjustment. That is another option available. Primary polypseudophakia. When calculated, this is another condition. When calculated, IOL power is much more than maximum available power, say like 48 diopters. And these lenses are pretty thick, so it would be more advisable to use best available, which you use about 32 diopters, and then correct the residual refractive error. And so we need 2 implants. Of course, the other one will be mostly in the sulcus. When it is a primary polypseudophakia, the preferred approach is to place 2 IOLs of different materials in different locations. That is, a lower portion, thin biconvex silicone lens in the ciliary sulcus and a high power negative shape factor acrylic lens in the capture bag. Calculating IOL power will be again a challenge, but he has placed 2 IOLs in the eye at the same operative session, or 6 steps IOL power calculation for polypseudophakia, wherein this is a long procedure. Measure the axial length as accurately as possible, and a small axial length error in extreme axial hyperopia is going to be of a big problems. Of course, the importance of optical biometer cannot be overstressed, and immersion 10 millihertz A-scan biometry is also reasonably good. Calculate the total IOL power needed in the plane of the capsular bag, not only in the sulcus. And for IOL power calculations, the settings of extreme hyperopia, the Holiday 2 formula is recommended. Hoffer-Q or a fully optimized version of the Haig's formula are now reasonable alternatives, though they are costly. They cost you for each for having them in your machine. And the other 2 variable third generation theoretic formulas, the SRKT and Holiday, will typically call for less IOL power than needed, resulting in post-operative hyperopia, which we never want. It is very important to be sure that the lens constant you will be using has been optimized. We had certain issues with the acrylic IOLs which had been brought in by the Indian companies, and I had also suffered a lot and had to implant a few of them because their optical A constants, especially the hydrophobic acrylic lenses, were not actually optimized in the first few years. Surgery of the non-dominant eye can be carried out. This is another one option. Just all these options are mix and match. You try to use whatever is best for you and whatever works best for you. In primary polypseudophakia, the Alcon MA50BM, which has a negative shape factor, majority of IOL power on the posterior surface, is the preferred lens for the capsular bag. Calculate the residual power. This is a step 3, and the highest power currently available is plus 30. We are just trying to talk about one platform, though other platforms might vary. And we will come up short in terms of the total IOL power required. Now the second diopter, the second lens has to be at least plus 17, and this is required at the level of the capsular bag for the right eye and 16 diopters for the left eye in order to achieve the desired target refraction. I hope you can see the chart that has been put here, right? Determine the power adjustment for the anterior lens, because the second lens is going to be in the ciliary sulcus, and the amount of power reduction required when removing an IOL from the capsular bag to the ciliary sulcus is proportional to the IOL power that can be determined by using the refractive versions formula. So this is how it goes: the residual IOL bag power and the sulcus adjustment. I'm sure you can take a snap of it. I'll not try to elaborate that. Calculate the power of the anterior IOL well. This is residual bag IOL power is say plus 17 for right eye, plus 16 for the left eye. The sulcus IOL powered adjustment will be for one diopter. This is what arbitrarily we have been doing. So this will reduce the IOL power by one diopter for the second lens. And select the appropriate polypseudophakia lens pair. It is recommended that different IOL materials in different locations can be used for the creation of a polypseudophakia lens pair, like the silicone and the acrosoph. So the end result for the right eye will be a capsular bag MS50 BM plus 30 right eye plus 30 left eye, while the ciliary sulcus silicone AQ2010V is 16 and 15. And this could be one of the, you can still go ahead and do one surgery, wait for the result, and then titrate your result for the second eye. This IOL combination lowers the likelihood of pigment dispersion. Why? Two different material, iris transillumination effects, intermittent uveitis or secondary glaucoma, and it also lessens the occurrence of the complications of interlenticular opacifications, which are very rife. So no hydrophilic lenses here. Thank you very much for the attention.